I'll move on to bladder cancer. Really, we're going to be talking about muscle invasive bladder cancer. So these are patients with T2 disease rather than the in situ or the superficial patients. So in general, there's two treatment modalities for muscle invasive bladder cancer. Cystectomy, obviously, removal of the bladder, prostate in men, uterus, tubes, and ovaries in women as well, with a lymph node dissection. More institutions in Europe kind of pioneered the bladder preservation, which involves a maximal transurethral resection of the bladder tumor, so surgery is still a part of it, followed by radiation and chemotherapy combined. And the classic way of doing it is with a mid-treatment evaluation with repeat cysto, biopsies, washings as part of that. And the goal is to have equal results but keep the bladder. And I think a lot of this would have stemmed from decades ago when the urologist didn't have as many options for bladder reconstruction, for generating a neobladder, doing an Indiana pouch, providing the patients with continent diversions. But now the urologists are really good at that. So patients, even after cystectomy, have good options for continence. So the rationale is that the tumor types are most commonly transitional cell carcinomas. They are sensitive to radiation and chemotherapy, both primarily platinum-based chemotherapy, but there are other regimens which are active. And this is the classic schema for that. This should have started with a maximal transurethral resection. So get all of the tumor out that the urologist can, and then treat with radiation and chemotherapy for about 4 to 5 weeks. Then repeat cysto, directed biopsies, random biopsies, and bladder washings. If there's no evidence of disease, the patient continues on to a total of 60 to 65 gray, continued with chemotherapy. If the patient has anything less than a complete response, that there's tumor cells in the washings or one of the biopsies come back with cancer, then the patient goes for a cystectomy. So that's the classic regimen. The ideal patients for this are those with a smaller, usually less than 5 centimeters, single tumor, no hydronephrosis, that their bladder is functional up front so that there's something worth preserving, that they have good kidney function so that they can take chemotherapy, and that they've had a maximal TURBT. This is just a lot of studies that have shown bladder preservation outcomes. The main thing that I wanted to highlight is this is the pathologic complete response rate. So when you do that cysto, when you do your follow-up cysto after the patient's completed, we're seeing no evidence of disease, usually in about 70 to 75% of patients. So those numbers are quite good. Bladder cancer is aggressive, so survival is lower. These patients also tend to be smokers and can have other comorbidities. But the survival at 3 to 5 years is usually about 50%. All of those numbers are comparable to radical cystectomy as well. But there's no randomized data of radical cystectomy versus bladder preservation. So there's no study that says head-to-head that they're equal. Based on all of the data that we have, the numbers are about the same. So I present them as equivalent options for patients. There's just a few points here as to why the patients aren't always the same. It just tends to be that younger patients go to surgery. Same thing with prostate cancer. They're healthier, more fit, can tolerate the big procedure. Patients who may be a little bit wary are the ones that come to see me about radiation. I included a few studies about quality of life following bladder preservation. In general, what the main question is, what good is preserving a bladder if it's not going to be functional afterwards? So if the patient still has to catheterize following radiation, then we didn't do that patient any good. An older study showed that there was worse quality of life with cystectomy versus bladder preservation. But that study is 21 years old now, and they likely weren't doing the continent diversions like you guys are today. So I don't put too much stock in that. But in general, if you're looking at patients who've had bladder preservation, for instance, they have good or have been able to salvage or maintain their bladder in about 2/3 of cases with long-term outcomes. Some of these patients still need to have a cystectomy if they have a non-functioning bladder afterwards. But in general, I think this is a good number. Satisfaction with bladder function. Before any treatment, 35%. 18 months later, 57%. So patients were more happy with their bladder function later. This likely dips down as those patient numbers get low as well. And here, a Harvard study, this is where most of the US bladder preservation data comes from. 2/3 had normal urinary function afterwards. And another 22% just had decreased compliance of their bladder, but pretty low rates of incontinence. So that indicates that there is good role for salvaging the bladder if the patient chooses.